توقعناش انها توصل للسن علشان يعني طبعا الجمهور ده يكون ان شاء الله احنا هنحقق
as we said, like if you concerned about opioid addiction or anything like that, you should not be concerned about opioid. If you have a patient with severe pain, we have to manage the pain. Prevention of vaso-occlusive crisis. The next is acute chest syndrome. ها؟ مش عارف. المطفية من هنا. ها؟ Of the lung. What is interesting that mostly is precipitated by infection with pneumonia, and the pneumonia itself will cause the acute chest syndrome, the opposite. And treatment of that, most of the treatment of acute chest syndrome, you have to give macrolides to cover for mycoplasma and chlamydia, and you have to give IV ceftriaxone or third generation cephalosporin or even fourth generation, but combine. The idea of combine, if you give only third generation, you may miss mycoplasma and chlamydia because they are acellular and they will not respond to ceftriaxone. If it is needed, but the main treatment, if it's like if the hemoglobin drop change, you need. But for acute chest syndrome, mainly antibiotic and hydration. But if it's not the standard to give to treat acute syndrome with transfusion unless it's needed. It's not the standard, but yes, if they need, they do. They use. Yeah, if you look it up at the management of acute syndrome, if they are hemolytic or they have decrease or change, you have to transfuse. But the management is mainly the most important thing to start antibiotic as soon as possible and combine macro. Change the transfusion, and in addition to the antibiotic. The next is priapism, is prolonged benign erection, and you have to provide pain medication, sits back, and you can do aspiration and irrigation with alpha agonist like phenylephrine. Neurological complication, if you have infarcts in the brain, it may cause symptoms of stroke like headache, seizure, hemiparesis, cerebral venous thrombosis, and the diagnosis with MRI, MRA, and also this will require transfusion. Thrombolytics? دي ما اعرفهاش. ان تدي thrombolytic for sickle cell anemia.
لا for acute crisis.
For acute crisis لا ادري. لا ما اصلش في سيرتها يعني في السورس يعني. Hydration and depending on the patient condition. For the kidney, it may cause gross hematuria, papillary necrosis. So general consideration in cases of sickle cell anemia, of course, is a chronic anemia. It may cause, and commonly will cause poor academic performance, delayed puberty. If you have a child coming to you with pinless limb, and and he has a history of sickle cell anemia, what is the most likely diagnosis or underlying condition? Like pinless limb, and he has sickle cell anemia. Yeah, exactly. What Burf's disease? Exactly, Burf's disease. So Burf's disease usually is pinless limb, and one of the common causes is sickle cell anemia, and will cause collapse of the femoral head. This slide will summarize like everything you said, vaso-occlusive crisis, pain, and the diagnosis clinical, analgesic and hydration. Acute chest syndrome usually present with fever, chest pain, hypoxemia. Chest X-ray will be diagnostic, or O2 analgesic, macrolides and ceftriaxone. If they have hypoxia, you will transfuse them. Stroke, headache, focal weakness and seizure. They diagnose MRI and the blood transfusion. Aplastic crisis, pallor, fatigue, altered mental status. They have anemia, reticulocytopenia, and the blood transfusion. Splenic sequestration, rapidly enlarging spleen, and the clinical would be drop in hemoglobin with reticulocytosis and the treatment transfusion. So we can review now the hemoglobin electrophoresis. And here, as you see here, hemoglobin S is slightly elevated, is less than 50%. This is sickle cell trait. Yeah, and the سبحان الله. ماشي مشكلة. ممكن anyone can tell me A is normal or abnormal? Normal. And what about that one? Electrophoresis. This is thalassemia trait, and this one you see no hemoglobin A. Huh? Yeah, this is thalassemia major. This is also sickle cell trait, sickle cell anemia. Okay, let's go to this case. We have an African American boy basically started on sulfa-methoxazole trimethoprim for UTI, presenting with sudden onset of dark urine, jaundice, and pallor, and the exam revealed splenomegaly and reticulocytosis. It has reticulocytosis, indirect hyperbilirubinemia, low haptoglobin. So you have the triad of hemolysis. Peripheral smear positive for Heinz body. So G6PD, the problem is the exposure of red blood cell to oxidative radicals. If you have reduced the glutathione, you have available G6PD, the body will continuously change the oxidized to reduced and will protect the red blood cells from the oxidative radicals like H2O2, like hydrogen peroxide. So if you have deficiency of G6PD, you will have a NAD will not be changed to NADPH, so you will have the glutathione always oxidized, not reduced. So the red blood cell would be damaged from the hydrogen peroxide or oxidative radicals. So this is what is glucose 6-phosphate dehydrogenase deficiency. The clinical point here, I would like to point that the half-life of G6PD is enough for a normal person, enough to continue for the 120 days of red blood cells. When someone has reduced, mildly reduced, like this is the African form, so mean that the older cells will be deficient in G6PD and will hemolyze with exposure to any oxidative drug or fava beans or anything. But this is a mild form, and it is common in Africa, and they usually protect them from malaria falciparum. The Mediterranean form is markedly reduced, so you will have maybe at the red blood cells the age of 60 and 90 and 120, they will have significant reduction of G6PD, and when they are exposed to any certain drugs, all of this will hemolyze. You will have only few left new red blood cells with good amount of G6PD. For that reason, if you test someone with G6PD activity at the time of hemolysis or shortly after, you will have normal negative or normal result of G6PD. Because all the new red blood cells that are high in G6PD, and it will give you false negative. So it's not a good time. You have to wait at least maybe 2 months or even 3 months to do that. But you can order peripheral smear. You can prove the diagnosis with the peripheral smear like Heinz body and white cell. So the G6PD is X-linked, primarily affected boys. The girls are just carrier. All the oxidative drugs, you know, including aspirin, sulfonamide, like Bactrim we use for UTI. Fava beans is more common in the Middle East because of the high consumption of fava beans. It's not like a cause, like for example in the US, because they will not really use it much. So here, as you see here, is normocytic anemia, is hemolytic. You will have Heinz bodies here in the peripheral smear, but this one, if you want to order it, will not show in the regular peripheral smear. You have to order a peripheral smear for G6PD. That's it. The pathologist will know what to, because it requires a special stain. It's called supravital stain. Will not be done with a regular blood film. You have to ask for it. And then this Heinz bodies, which is a denatured hemoglobin precipitated at one side of the red blood cells, will be bitten by the macrophage and then will give you a bite cell. So the screen is not showing, but the bite cells will be one missing like that because it's bitten by the macrophage. And then you have to do if you want to confirm the diagnosis, wait 3 months after the hemolytic episode, then you can do G6PD activity in red blood cell. It will show that is reduced. Luckily, the G6PD you don't have to treat. So there is no treatment unless if they have severe episode of hemolysis, then you might transfuse them. Okay, we have an interesting case. This one is important because it can happen to any healthy adolescent. You have a 12-year-old girl presents with fatigue, sudden onset of fatigue, after having upper respiratory tract infection a couple weeks ago. She's pale, her eyes are yellow, her spleen is enlarged, laboratory show hemoglobin at 6.9, MSC, HC at 35 is high, reticulocyte count is high unconjugated bilirubin, high LDH, positive direct antiglobulin test, and the peripheral is normocytic, and the renal function is normal. What is the most likely? This is autoimmune hemolytic anemia. So autohemolytic anemia because of antibodies against the red blood cells. The most common we see in pediatrics is IgE mediated. And usually this is warm because the IgG will combine with the red blood cells and then will cause extravascular hemolysis. Will go to the spleen and the spleen will break down the red blood cells, and this is usually in the circulation inside. But the IgM mediated will break down in the peripheral circulation in the hands and toes because it's cold. The cold temperature, so will start to break down, and this is commonly triggered by mycoplasma or EBV virus. But the IgG, this is the most common we see in pediatrics, is usually extravascular like the previous case. And they will present with the same presentation of hemolytic anemia. They will have pallor, jaundice, fever, and the spleen will be enlarged. The lab, you will order the lab when you suspect hemolytic anemia. Again, you order all the lab for hemolytic anemia. You will see profound anemia, the hemoglobin is low, reticulocytosis, the body trying to compensate, and you have jaundice, high level of unconjugated bilirubin. This is the test. When you order this test, the Combs test, direct, not indirect, direct to Combs test, or well known as antiglobulin test, will be positive, high MSC, HC, and spherocytosis. So autoimmune hemolytic anemia will give you similar peripheral smear to spherocytosis. And also high MSC, HC, which is also high in spherocytosis. And if it's triggered by mycoplasma, you will see high cold agglutinin IgM. The treatment is supportive, corticosteroids, blood transfusion, IVIG, and splenectomy. This slide just to summarize all the rare conditions. All the rare diseases affected, suffering from anemia, they will have other manifestations, not just they will have abnormal facial features, they have combination of other problems. Like Pearson disease, they have sideroblastic anemia and pancreatic dysfunction, but no skeletal abnormalities. Schwachman-Diamond syndrome, they have neutropenia with pancreatic dysfunction, but they are short, they have a skeletal abnormalities. Diamond-Blackfan anemia, they have pure red blood cell aplasia, macrocytic plus also triphalangeal thumb or abnormal facial features. Fanconi anemia, they are very sick, they suffer from pancytopenia, they are short, they have also abnormal thumb and skeletal abnormality. This is very important, the neutropenia. Neutropenia, we have to differentiate between serious and benign neutropenia. Most of the cases we see all the time is not serious, like benign neutropenia, transient neutropenia because of exposure to viruses. Okay, so the longer the duration a child will have neutropenia, the worse the complication. The more serious if someone has neutropenia for a long time, not just for a couple of weeks because of exposure to a virus, no, long time. So if you have ANC less than 500 and in a healthy child with no symptoms, and because of exposure to viral infection, this is transient and will recover with no complications. On the other hand, if you have ANC less than 500 in a child who is febrile, receiving chemotherapy, this is very serious. This child must be admitted for blood culture, antibiotics, because they can develop serious infections. If you have ANC less than 100 in a child with severe congenital neutropenia like Kusterman syndrome, this is life-threatening and they can suffer from serious infections. So it depends on the duration, it depends on the underlying condition. Healthy children with viral infection and neutropenia is transient, and as long as they are healthy, you just watch for fever. If they develop fever, you need to manage, but if they don't have fever, you just watch them, even if it's less than 500. So the causes of neutropenia, viral infection, bacterial infection, hypersplenism. We have a cyclic neutropenia. This neutropenia every 21 days. So you need to order CBC every 2 to 3 weeks to make the diagnosis of cyclic neutropenia. They may suffer or they may develop infection during the nadir when the white count is the lowest. In this case, you can manage with antibiotic, and also you can protect with granulocyte colony stimulating factor. This one is important, and this one you will see all the time. Some kids, they have chronic benign neutropenia. They have ANC less than 500, sometimes less than 200, between 200 and 500, and is a diagnosis of exclusion, and no treatment is required as long as they are healthy. Because normally a child may have few ear infection per year, they may have viral infection, few viral infection, but if the child is having, like, say, recurrent pneumonia, recurrent admission to the hospital, osteomyelitis, meningitis, these are serious. But viral infection like chronic nose condition, anyone with normal neutrophil can have that as well. So, if the neutropenia is autoimmune, this can be serious, and can the white count can be low or ANC go down even to 0, and this is because of autoimmune antibodies against the white blood cells. Kusterman syndrome is rare, and this can cause severe neutropenia, and usually ANC less than 100. This can be associated with severe pneumonia, deep abscess or deep infection in the body, and they can be life-threatening. It's important to know that you never do rectal temperature for any neutropenic patient or any patient with or any oncologic patient. Any patient visiting a hematologist for any type of leukemia, never do rectal temperature. So in reality, in pediatrics, you don't need to do rectal temperature except in NICU. This is a different group. But in regular pediatric clinic, just the head or the ear, that's enough, or the mouth. So thrombocytopenia, I will discuss it now. This is the final part of the presentation, platelets. Only CBC. You have a child with so you ask, you take the history, you examine the child. All the exam is normal. Then you order a CBC, and the CBC, all the cell lines are normal, and he doesn't have any serious infection, just a regular. you don't have to do anything, just to you may repeat the CBC in another 3 weeks. That's it. And you can repeat that for 3 cycles. If you see it goes down and up, you know this is cycling. If it continues, this is chronic benign, and it is still no treatment. Yeah, but when they suffer from infection, they get serious infection, then I will send them to hematologist to maybe give them the granulocyte colony stimulating factors.
لو هعمل ادميشن لعيان بقى نيوتروبينيا في مثلا انت ممكن تشوز
Huh? Yeah, he's asking if you have a patient with neutropenia and is symptomatic, what antibiotic would you choose to give? You have to give combination of something to cover for cellular bacteria and the acellular. So you have to give, like, say, if it's outpatient, you will give augmentin. That's a good one. It will cover for most of them. If it's in the hospital, you have at least to give third generation cephalosporin. And if you see any signs of pneumonia or anything, you have to add something for mycoplasma, like azithromycin. For congenital causes of thrombocytopenia, TAR syndrome is more common in the exams, so it's worth it to know the TAR syndrome. It's thrombocytopenia with absent radius, usually present in boys after birth when they do the circumcision, so you see the bleeding doesn't stop. But it's rare, which is luckily is rare. Causes of thrombocytopenia, immune and non-immune. Immune is like immune thrombocytopenia. This used to be idiopathic thrombocytopenic purpura, the name changed, and drugs can do that. Non-immune, like thrombotic thrombocytopenic purpura, this is rare. HUS, you may see it. DIC, infection and cardiac causes. This case is very important. If we finish here, this is a good message to take with you home. This case is a 4-year-old boy presents with recurrent nose bleeding, bruises on the leg and the arms, and it also has few petechiae on the tongue and the hard palate. This actual case, I had it in my clinic. And they know hepatosplenomegaly, no lymphadenopathy, CBC is normal except the platelet 2000, and he has no headaches, no other symptom. What is the next step? Corticosteroids, IVIG, close observation, or I don't know what I said there. It's wrong anyway. Huh? Exactly, close observation. This is the best thing to do for children with immune thrombocytopenic purpura.
فين ده رقم 2000
Huh?
فين
Even if it's 2000. Still observe. This is the new guideline. We used to have parameters is less than 10,000. You have to give this. No more. This is changed recently. So no, just a close observation. That's it. No medicine. Yeah, if a child is high risk, like hyperactive, some hematologists will give medicine because of high risk of intracranial pneumonia. Yeah, but if it's an older child and is like this child, we didn't give him anything, and he's okay now. I saw him when he was 4, now he's 8. He's fine. 24 hours? To repeat the lab? No, you can do it in a week, then when it's good you can do it in 2 weeks, then you have to keep it, because it might take up to 6 months to go back to normal, so it takes a long time. So as long as, because you were always about leukemia, because in the repeat, if you start to see white count is changing and it starts to be anemic, then the bone marrow has to be done. But as long as it stays normal, and for mild bleeding, like epistaxis, but if it's moderate to severe hemorrhage, like severe epistaxis, you have to treat. And the first line is corticosteroid. Huh? Platelet transfusion is useless. Why? Because he has antibiotics, except the platelet is low, just to close observation. Okay? If mild bleeding, if moderate to severe bleeding, the treatment is corticosteroid. And if it's not enough, you can add IVIG or Winroll. And if when to give blood platelet transfusion only if the child has intracranial bleeding, because you want to save some time. You want to, he's going to die, so you have to do something. So this is the only condition we do platelet transfusion, intracranial bleeding, like life-threatening hemorrhage, like it's about to die. So we give them the only option. But IVIG, and also there is some immune. Huh? 5-year-old boy with history of bloody diarrhea for the last 5 days started to have be pale and having poor urine output. Was started in oral antibiotic. The labs are significant for severe anemia, thrombocytopenia, abnormal kidney function. You have signs of acute kidney injury, schistocytes in the peripheral sphere, and the DOA was positive for red blood cell cancer, and the blood culture or stool culture is still pending. What is the most likely hemolytic uremic syndrome? So the triad of by the toxins from the bacteria like Shiga toxin from the E. coli, most commonly 0157, or the Shigella dysentery. This can cause injury to the small blood vessels. That's why microangiopathic. And this, if it goes to the kidney, will make clots in the kidney and will make the ischemia. And from the ischemia will cause hemolysis and low platelets. So you have breakdown of platelets, hemolysis, plus the signs of acute kidney injury. And this type of bacteria, you don't need to give antibiotic for that. And one general rule, most of the patients, they come to me with diarrhea, I don't rush for antibiotic. Most 99% of diarrhea, even if it's bloody, nothing will happen. It will go away by itself. Bloody diarrhea is not life-threatening. So you don't have to rush to give antibiotic. Number one, if you worry about it, and you can do stool culture. And recently you can do stool GI biofire. Now with a more advanced lab to give you a large number of pathogens, it can cause the diarrhea. And don't give antibiotic, is already improving. So like the guy, some probiotics, any probiotic, even yogurt, just some زبادي يعني.
Only if high fever مع blood antibiotics prescribed.
I wouldn't.
WHO قرر في high fever مع blood diarrhea.
If the child is looking like sick enough, if the child usually this is general, if the child sick enough to be hospitalized, this is you may consider the antibiotic. But if it's healthy looking, coming to the clinic, is laughing, is smiling, and she bring you a diaper or showing a picture of blood in his stool, and he's okay, you don't have to rush just to do the stool culture first and see the ID to make sure it's not that, it's not the E. coli 0, so you don't, because it's common with antibiotic to cause hemolytic uremic syndrome, which is life-threatening. So instead of he's going to be fine, you send him to PICU because of antibiotics. So, and even for babies, when they have blood in the stool, don't panic, it's okay. It's not like, he will not die from blood in the stool. So we have to take our time to investigate and find out why. So we have bloody diarrhea, it's not dangerous, it's not life-threatening. But if the child is dehydrated, moderate to severe dehydration, looking ill, poor oral intake, he doesn't want to drink anything, you need to hospitalize. So this is the one you have to treat. Also, if someone less than 3 months of age and is having bloody diarrhea, this is their immune system extracting 24 to 32 ounces of cow's milk formula, and the height and weight are normal, temperature is 38 Celsius, and the pulse rate 120, respiratory rate, blood pressure is okay. On examination, the infant is fussy but consolable. He has petechiae on the body, and he has erythematous dry or eczematous rash on the cheek, and the ear is bulging, like he has infection, and no renal fissure, and the rest of the exam is normal. White count is normal, hemoglobin is normal, MCV is normal, platelet count is low, 45. And the main platelet volume, that's why I mentioned that in the very beginning, is small. 5 femtoliter is small. So you have a small platelet. What is the most likely diagnosis? Wiskott Aldrich. Thank you. So Wiskott Aldrich is a rare X-linked disorder, primarily affect boys. Girls are carried because of defecting WAS gene. They present with nosebleeds or petechiae, thrombocytopenia, small size platelets, eczema. They have immune deficiency. They present also with recurrent infection. So here you have large platelets, immune thrombocytopenia, small platelets, Wiskott-Aldrich. Kasabach-Merritt syndrome, if you have someone with large vascular tumor, it may consume the platelets and will cause thrombocytopenia, hemolytic anemia, coagulopathy. This one needed to be referred to hematologist. So I'm almost done, it's only a few slides later. Right? So we have to do coagulopathy. So very important, it comes now in the board exam, the mixing study. And so what is the mixing study? If you have someone with prolonged PT and PTT, you do mixing study. So mixing study is to mix the patient plasma with normal plasma. Okay? And if you see, if it doesn't correct, you know there is some antibodies causing the prolonged PT or PTT. Like for example, lupus, antiphospholipid syndrome. But if it corrects, it means that you have some factor deficiency. If it's prolonged PT, you know this is the extrinsic pathway and will be factor 7 vitamin K deficiency. If PTT is prolonged, this is intrinsic pathway, so you are dealing with factor 8, factor 9, 11 and 12. So this is the last disease I will discuss, von Willebrand disease. Von Willebrand disease, most commonly we see it in young girls, like the one they start their period and will start to be heavy, like 11, 12 years old girl coming with heavy menstruation, taking forever to stop, and they start to have some iron deficiency anemia. So when you see that, suspect or you have to test this girl for von Willebrand disease. Sometimes this will be the initial presentation. The von Willebrand disease. Some kids they will suffer from epistaxis or recurrent nose bleeding. We have 3 different types. I will not go in details here. You have type 1. This is the most common. Type 1 is because of partial deficiency of von Willebrand disease. Let me explain. This one is important. Von Willebrand disease is von Willebrand factor is stored in the endothelial cells and the platelets. And whenever anyone does exercise or stress or anything like that, transiently the von Willebrand factor will increase. So if someone has deficiency, congenital deficiency, this may mask, like after surgery, exercise, any stress, it may mask and may make the von Willebrand factor elevated and will make it difficult for you to make the diagnosis. Okay, so diagnosis von Willebrand disease is sometimes difficult and challenging. Sometimes the PT is normal. PT is normal anyway, but PTT sometimes is normal. Factor 8 is normal. Von Willebrand factor is normal. Everything is normal. So maybe because of stress or mild in case of von Willebrand disease. But the type 3, for example, is severe, and they have absent von Willebrand factor, and this is the one they will have severe hemorrhage, mimic hemophilia. But the mild one, the most common one we see all the time is autosomal dominant type 1. This is the one sometimes is difficult to diagnose. But anyway, if you have a history, personal history of mucocutaneous bleeding like epistaxis or severe bleeding after dental extraction or after tonsillectomy, and family history of bleeding, like you ask, yeah, my mom used to bleed a lot, my father, like because autosomal dominant can be boys and girls. So you have to test. You can send this von Willebrand panel, and will show if it's between 30 and 50, this is enough to make the diagnosis. But classically, if it's less than 30, will confirm the diagnosis. So the presentation: excessive bleeding, epistaxis, menorrhagia, post-operative bleeding, and PTT will be frequently normal in type 1, but may be prolonged. PT, of course, is different, is normal in von Willebrand. Von Willebrand antigen will be low, and von Willebrand restocytin cofactor activity will be low. And factor 8 activity, why? Because factor 8 is related to von Willebrand, because von Willebrand is a carrier to factor 8. They work together to make a clot. So finally, I will conclude with this slide. The treatment is DDAVP for von Willebrand. It can be nasal or oral, 1 to 2 hours before surgery. Also recombinant von Willebrand or von Willebrand factor 8 concentrate. Also before surgery, before dental procedure, you can use antifibrinolytic like aminocaproic acid or tranexamic acid. And now I think all of you now are more comfortable reading CBC, right? That's it. This is the final slide. Any question? Huh? Is 1 milligram per kilo, that's it.
طيب سؤال تاني بالنسبه للبليدنج بروفايل بفور سيركمسيجن بتعملوها ايه في امريكا يعني بتعمل بليدنج بروفايل؟
No bleeding profile. Zero.
As no family history.
Yeah, no family history of anything, you do the circumcision. If he bleeds, you start to react. Yeah.
Something الايرن يكون بريتيرم لان في الايجيبشن جيال بيتكلموا على اسبوعين اعتقد ان اكثر جايد 1 month.
Because
which
yeah, the one I know is it could be updated. I have to look it up, but the one I know is 1 month. You start for preterm babies at 1 month. But if extreme preterm and they stay in NICU, it has to be discharged in oral iron. Like most of the kids in the US when they are preterm, they are discharged in oral iron. Yeah, like double the dose of the regular full term, like 2 milligrams per kilo per day. But for preterm, 1 milligram per kilo per day.
هل الانافلاكتويد بيربرب في تغيير في السي بي سي؟
ها؟
الانافلاكتويد بيربرب في تغيير في السي بي سي؟
Anaphylaxis? دي لا ممكن لو if you give him IV fluid and hemodilution like you did the test before admission as hemoglobin for example is 12 and after you give him bolus and all of that and hemoglobin is 9. This is hemodilution but you will see that is normocytic.
الهاي بيرفورمانس اتش بي
حاجه
ال
زي
سي
الهيموجلوبين الكتروفوريسيس
بس
HbA1c,
شويه
which is more accurate in diagnosis of thalassemia, either alpha or beta.
Okay.
يعني لو انا عملنا الهيموجلوبين الكتروفوريسيس لبعض الحالات اللي شاكين اللي هي في النينيتال ايج انها الفا ثلاسيميا وطلع نورمال بنبروسيد للاتش بي ال سي على اساس ان هو اعلى او ضغط بيبان فيه اللي هو الكالر زون اللي بيميز الالفا ثلاسيميا.
ما عنديش فكره عنها، ما عنديش علم فيه. بس I know the standard like for alpha thalassemia if you suspect alpha thalassemia to do genetic test. Genetic mutation.
What about premarital counseling for patient with alpha thalassemia? Patient with alpha thalassemia, premarital counseling. Yes. What to do?
الكونسلنج
اها هي اوتيزم ريسيسيف والله دي مشكله يعني ما عنديش علم بيها بصراحه يعني لو هم الافضل ما يتجوزوش طبعا لان لو الطفل عنده مثلا 3 جين 3 جين ديليجن او 4 هيموت يعني
في الطفل هيموت بيمنعوا الزواج اصلا وبيعملوا ده علشان كان عندهم الريت عالي جدا للبيتا ثلاسيميا.
البيتا حتى في الجلف اريا برضه نفس الشيء، لكن انا كلامي عن الالفا ثلاسيميا.
الالفا ثلاسيميا if the transmission like 4 gene will be hydroxylase لو 3 gene will be H hemoglobin H which is a severe form of alpha thalassemia. And I remember I saw one case here of hemoglobin H alpha thalassemia, and this child came to me for a second opinion, and the dad brought a lot of investigations, and the child was treated for many years. She was in high school, and I asked Dr. Ashraf about her. He referred me to someone, hematologist in Mansoura. But this girl, she was given a large amount of iron. When she came to me, I saw her, she was like bronzy color. She feel like she's like a child with hemosiderosis, too much iron. From one pediatrician give her iron, another pediatrician give her iron, and she has thalassemia, but everybody convinced that she has iron deficiency anemia, and the ferritin is not. So it's important for us to, before we treat a thalassemia, they will not need iron. So if we understand that today, like we'll save a lot of kids from taking iron for no reason.
دكتور أسامة معلش في حالات احنا
تعالي امسك المايك بقى.
انها اوتو اميون، وكمان انا صوتي عالي، في حالات بنبقى شاكين انها اوتو اميون او اميون هيموليتيك انيميا، وحتى ساعات نيجي نقعد نعمل التوافق ما بيحصلش توافق، ومع ذلك الكومبس يطلع نيجاتيف. نادرا يعني نادرا فعلا حد شاف عمره الكومبس بوزيتيف في حاله شاكك انها فعلا اميون. هل في خطا في اللاب؟ يعني هل في بريكوشنز معينه؟
ما اعرفش الاكيورسي او اللاب هنا ازاي. ما اعرفش لان في اتفضل. No treatment, and we have to be honest with parents. There is no treatment. You transfuse if they are symptomatic, and folic acid, but not iron. So most important not to give them iron. So folic acid, if they, and then you send them if they are like H alpha thalassemia, hemoglobin H alpha thalassemia. This patient they must be seen by hematologists, because if they are doing a research and they are able to do hematopoietic transplant or something, maybe it will also they may do splenectomy, it may help. So if you have, but alpha thalassemia grade zero treatment, nothing, no iron, nothing, and no even folic acid because no symptoms.
So just the diagnosis for alpha thalassemia genetic.
And this child, when I sent her to this doctor in Mansoura, he's very good. I don't remember his name.
احمد درويش.
Ahmed Darwish. Yeah, he's very nice. I'm not advertising him, okay? He's good.
لا احنا عارفين ده.
I don't know. You know him, okay? So he's very good, and he did a genetic test, and he just he was truthful with them. He told them this is the diagnosis and no treatment. That's it. So because the father is going from one to another, and everybody, oh, this iron is low. Okay, take more and more iron. And the girl was like intoxicated with iron.
كمان في
بالنسبه لنا دكتور محمد سرحان ربنا يصحه يا رب كان دايما استاذ هيماتولوجي اطفال كان قال لنا معلومه في مره ان ما تنخدعش بالريتيكولوسيتيك كاونت في حالات الهيموليسيس، يعني لان ممكن حتى بالكوركشن ممكن يطلع لك لو نورمال ايفن لو كمان في حالات السيفير هيموليسيس زي حالات الثلاسيميا ميجور وكده. فالمعلومه دي بصراحه كان اول مره ان انا اسمعها. فحضرتك
You don't base your diagnosis on reticulocyte count, but it's all suggestive. You have to look at the whole picture, everything together. But for one thing, I'm not a hematologist, okay? In severe cases, G6PD general no treatment. But only in severe cases. Someone hospitalized all the time, breaking down his blood all the time. It's different.
الاكل الممنوع في G6PD.
Huh?
الاكل الممنوع في G6PD.
The food will trigger it like fava beans.
اي حاجه
fava beans.
لا بس اي حاجه، اصل هو الكلام اللي انا اخر حاجه انا سمعتها انا عايز اسالكم عشان اعرف يعني ابقى ابديتد. يعني اخر حاجه انا اعرفها الفول واي حاجه فول تمام والبسله فقط. الفول والبسله
انا اعرف ناس
فقط.
جالهم من الكاجو يا دكتور اشرف، يعني كان في ناس كاجو ولب
هو احنا عايزين
نعرف
انا عايز ابقى ابديتد من الموضوع ده. اخر حاجه انا سمعتها من اساتذه الهيماتولوجي الفول والبسله فقط، بقيه الحاجات بتاكل عادي. انا الطفل بيتعذب يعني.
بارشر ولا
يعني عند سن معين بيحصلوا اتاك والناس تقدر وفي ناس جاتها من بدري بس هي حسب التشخيص حسب الانزيم
But the new red blood cells will have high G6PD. شكرا لكم.
ان شاء الله الاسبوع الجاي كان على ميعادنا هنا يعني ما لم يحدث جديد من البلد ما حصلش جديد هيبقى هنا الميعاد ان شاء الله.
الشهاده هيبلغ على الصفاء بالاسم بالكامل على الواتس.
واللي يرغب في شهاده هيبقى في الساعه 11 يبقى الهيماتولوجي ان شاء الله يكون في الشهاده.
بس اللي يرغب في الشهاده دي عايزين ناجلها شويه دكتور عثمان لما عدد السيشن يبقى كتير. يعني احنا عندنا 8 مثلا، لو حد حضر 6 هنعمل له شهاده، انما لو حد حضر واحده مش هنعمل شهاده. اكيد يعني.
اللي عايز يجي يسجل على الفيس يبقى معانا على طول. هنسجل ان هو ناوي عايز
بالظبط كده.
لان المديرين قالوا على كده بلغونا الناس اللي عايزه شهاده.
ان شاء الله.
شكرا جزيلا لكم جميعا وربنا يجعله يعني دفع بين ويجعله خالص
ها يلا طويل ورا طويل ورا زي ما انت تبقى صفين يا جماعه.
واعملها على